Good afternoon, everyone. I would like to welcome you to today's presentation brought to you on behalf of the National Center of Excellence for Eating Disorders and the African American Behavioral Center of Excellence. I wanted to start off with a few things to note. Participants will be muted upon entry and videos turned off. For technical assistance, we ask that you use the chat box. You will also receive an email in approximately 3 months requesting feedback/impact on today's presentation. We also are going to provide you with additional training materials that we offer via our training center. And to view those, we'd ask for you to join www.ncdas.org/training. You will also receive a copy of today's slides tomorrow via email. And for your certifications, you will receive information at the end of today's presentation for contact regarding which certificate you would like to receive for your continued education credits. I'll now go ahead and introduce today's presenter, Dr. Rachel Good, who will be presenting on the title, No More Secrets, Shedding Light on Eating Disorders in the African American Community. Dr. Rachel Good is an assistant professor at the School of Social Work, University of North Carolina at Chapel Hill, and a key content expert with the National Center of Excellence for Eating Disorders. The focus of her research is to develop, implement, and evaluate interventions to prevent and treat disordered eating and obesity among African American women. Her ongoing projects include a NIH Career Development Award to develop a culturally relevant digital treatment for the treatment of binge eating in Black Americans, and 2, an innovative clinical translational science award from the American Diabetes Association to improve treatment for binge eating among African Americans with type 2 diabetes. I will now go ahead and turn things over to Dr. Rachel Good.
Thank you for that introduction, Lachelle. I am excited to be here with you all today to talk about eating disorders in Black Americans in our community. You know, there's so much that we still don't know. And so I'm looking forward to just us beginning a conversation, right? Having a dialogue with one another as we really begin to highlight something that has not been talked about as much among Black Americans. And hopefully that we will take our steps to change that. So I just want to honor the sponsors for our presentation today. First, I want to honor NSEED for their mission to advance education and training of healthcare providers and to help increase awareness of eating disorders and eating disorder treatment. And then I also want to honor the African American Behavioral Health Center of Excellence. Just grateful for the work that you're doing to just improve our access to behavioral health treatment and educating us on the various programs and systems that might be helpful. So today, the purpose of our talk today is, one, we're going to do a couple of things. We're going to examine and describe the prevalence of DSM-5 eating disorders and some of our challenges in access and treatment retention for Black Americans. We're going to discuss relevant factors in the development of eating disorders in Black Americans. And then we are going to discuss some strategies for some culturally relevant assessment tools and the treatment of disordered eating behaviors. I think one of the first things that's important to discuss, and I often do this in many of my presentations, is we have to talk about, there's so much we don't know about eating disorders. And so when I think about what's relevant for Black Americans, I think the first thing that jumps out to me is that eating disorders can affect anyone. Okay, and so I think we have been harmed by misconceptions outside of our community, within our communities, that only certain people get eating disorders, but that is not true. They affect people of all ages, races, ethnicities, and genders. Also, you cannot tell someone has an eating disorder just by looking at them. This has also negatively impacted many in the Black American community because people have assumed that because maybe our body types are different or certain symptoms look different, we do not have eating disorders. And again, that is not true. And hopefully by the end of our presentation, you all will have some more information to help continue to improve our dialogue and our knowledge on this topic. So this is the image of who we have believed, right? Eating disorders have typically been assumed to be a white, adolescent, cisgender, female concern. And so, but the truth is that we all of us have the potential to have an eating disorder, especially living in a country where weight has been at the forefront of dialogue for many, many years. It is very easy to begin a disordered relationship with your body, and that translate into disordered eating. And so as we recognize that all of us can have eating disorders, it's important to acknowledge some of the stereotypes, right? And to go beyond that. So if we really look at the evidence, binge eating disorder is the most common eating disorder in Black Americans. In fact, rates of binge eating may be similar or even higher in Black Americans as compared to whites. And among those who are experiencing food insecurity, and they endorsing the highest levels, we see significantly higher levels of binge eating and eating disorder pathology. We also recognize that body image dissatisfaction is something that plagues Black Americans, and as particularly among women, being dissatisfied with one's body image is a strong predictor of binge eating in Black women. So historically, we have thought, again, Black women, oh no, they don't struggle with body image in the same way. You know, we like curvier figures. We prefer, you know, we don't have as much, I don't know, there's not as much stigma about carrying excess weight, but that does not mean that there are not people who feel like they want their body size to be different. And what we see is that relationship between the experience of body image dissatisfaction and eating disorders. We see the highest rates of body dissatisfaction when individuals are preferring a body type that might be more endorsed by mainstream culture, and they're buying into some of those norms. We see some of the most, the strongest relationship between body dissatisfaction and eating disorders. And so we're learning that we need to continue to investigate this relationship in Black Americans, because this is still here. Body image is still a concern, and we are going to have to learn more about how it's related and how to treat it, especially when it comes to the treatment of eating disorders. So when we think about, these are the three most common eating disorders. Not every eating disorder is not present here, but anorexia nervosa, bulimia nervosa, and binge eating disorder are the three most common eating disorders here. And so what we see is that among Black Americans, binge eating disorder and bulimia nervosa are some of the most common. So this is the lifetime prevalence of these eating disorders in our population. And so the one thing you might think of, oh, 1.4% or 1.6%, like that seems very small. But I think what's most important to realize is that eating disorders are not typically treated. People aren't usually going in to get help, particularly when we might even realize that an eating disorder could be present. So these numbers likely underestimate greatly the prevalence of some of this disordered eating that might be present in our communities. We have to consider just some of the factors that might affect the development of disordered eating and how it might look different in Black Americans. So one thing I think that's been protective, but not completely protective, is that there are just some alternative views of weight and shape. And so I read in a text, and I loved how the author said this, there's just an increased flexibility when it comes to body shape. There's still ideals, definitely, but there's just an increased flexibility, right? And so there's less emphasis on achieving the thin ideal. In addition, there might be just a lack of eating disorder awareness due to those stereotypes, where we might have just believed that Black Americans don't struggle with eating disorders. And so because of that, I think culturally, there isn't a lot of information on what an eating disorder is, how might I know I have an eating disorder, and these are things that might make it challenging for many to get the help that they need. We also have to consider, what does food mean within our culture, right? When you think about historically, Black Americans have had to be, especially Black women, had to be mosaics, creating architects of beauty with little to anything, often with scraps that were left over. When you think about slavery, after we were freed, we were sharecroppers, thinking we did not have much. And so we had to make it be beautiful. And so because of that, food has been something that culturally we are very proud of, and it means a lot. It sends love to each other when we are cooking and sharing food with one another. And so in order to understand how disordered eating might develop, we have to understand that context and recognize that food can be a form of coping, and it can be something that is used, and we'll continue to see in this presentation, that can be used to really kind of be a shelter from the outside world. And I think in Black American culture, it has really been something that has been very comforting and a very protective part of our culture. So I wanted to share this clip of a young woman talking about her experience managing an eating disorder. And I think it'll set a good tone for our conversation today.
As a Black woman with anorexia, it's a different experience because I not only have to kind of deal with all the eating disorder symptoms that are already there, but I have to deal with how it relates to my racial identity. Knowing that my body as a Black woman is never going to look like a white woman's. I am not going to be underweight due to muscle mass and bone density. And so having all of the symptoms of someone with anorexia and really struggling, but sometimes not getting treatment because I'm not underweight, so I can't be admitted places or have an official diagnosis. Or if I do have the diagnosis, still feeling so much denial about it because I have a voice in my head telling me that I don't have this, or that I'm not sick enough, I'm not thin enough to be anorexic, but also having the outside world not really be able to see it either. It feels isolating. It feels isolating knowing that this isn't something that a lot of Black women have shared their stories of having anorexia and being somebody who deals with that. It feels like I'm sort of in between, like I don't get to be a Black person, but I'm not a white person either. I just kind of am stuck in this lonely place. And I'm not really sure where to go from there. When I talk about it in treatment, most of the doctors are white, and so they don't really understand what it's like for me from a cultural perspective. They can be educated about it, but truly getting it, to find somebody who really gets it, is hard. So it feels very alone. I would say to treatment providers and clinicians to not assume that because somebody looks a certain way that they have a disorder or not. A lot of the time, Black women it's assumed that they don't have an eating disorder. Anorexia, bulimia, binge eating disorder, it's not even screened. So I would just say that to remember that eating disorders don't have a face, they don't have a representative. They can be in anyone, and they don't discriminate. And so in the world of treatment, we shouldn't either. We should look at it, the diagnosis and the eating disorder, for what it is, and see that it can affect anybody, and treat everyone who has them, because everyone deserves help. Everyone deserves to be seen, no matter the body that they're in or the skin color that they have.
What I hope you all will take from this brave young woman who was speaking is just a reminder, right? We have so many misconceptions that we have to kind of push back against, and who is often left suffering are those who are kind of needing the help at the time. So it's going to be so important as we move forward that we work to uncover the truth about eating disorders and really prepare our practitioners so that they can effectively practice to help treat and help our people to heal. So I think I use that video to begin our discussion on the factors contributing to disordered eating in Black Americans, what we've seen in the research literature. We think about some of the commonly held beliefs that the over-evaluation of shape or weight is kind of the reason why an eating disorder would develop. And that is one factor, definitely. But you see here, there are other things that we've seen in the research that affect disordered eating, the development of eating disorders in Black Americans. And we're going to take the time to unpack them bit by bit. So one of the first ones that I think it's important to see is the role of poverty and food insecurity. And you can imagine if you grew up in a home where access to food was limited and you weren't certain of where you were going to get your next meal. So you might have experienced periods of restriction, right? Or deprivation, because you have sensed that you weren't able to access food at the place where you wanted to access it, whether you skip meals, whether you might find yourself trying to maybe overindulge on food when it's available so that it can, because there might be a period when it's not available. And so we see these patterns really showing up among individuals who are experiencing either previously have experienced, maybe grew up in childhood poverty, or might currently be experiencing food insecurity. And so when we see, particularly among individuals who are in households where they are experiencing the various highest levels of food insecurity, meaning there are children in the home who they are not certain that they're going to have food to feed. When we see individuals in those circumstances, we see higher levels of binge eating, higher levels overall of eating disorder pathology. We see higher levels of weight stigma. These are things that are present. While people are managing the context of poverty, we see these other things this disordered eating develops as well. We also acknowledge the role of trauma. And so individuals who have experienced childhood sexual trauma, childhood, other traumatic events that might have happened, we see higher rates of disordered eating. And so some researchers have theorized that part of the reason for this might be the body's way of coping with the trauma and being able to kind of put it somewhere. And so a place, sometimes when individuals cannot control some of the things that are happening to them, they often are able to control what they're eating and be able to put the focus there. And so we see that disordered eating can be often a result of some of these traumatic experiences. We also cannot talk enough about the experience of racism and discrimination and microaggressions when it comes to disordered eating. We have to think about, often we see this really show itself when individuals are maybe in environments where they might be the only person of color, the only Black person in a work environment that's predominantly white. And so when it comes to we think about body type and feeling the pressure of acculturation, sometimes individuals in these spaces have developed disordered eating as a way, as they're managing that sense of just not fitting in their environment and the pressure, sometimes the rate stigma that they're experiencing. And one thing that they can do, even though of course, they cannot change their skin color, or they may not even want to, but to have a body type that fits the norm that might be seen in the dominant culture. In addition, sometimes individuals are managing, and we see when those who have experienced higher rates of discrimination, we see a relationship sometimes between coping tools, and the eating behaviors can often just be a tool to cope with some of those experiences, a way to speak things that sometimes we don't have the words to speak. We can use our eating, and it's a way for us to communicate some things that might be very painful. We also have some research to think about the role of strong Black woman syndrome. So this is the pressure sometimes Black women feel to kind of be all things to all people, to not say that you have had enough, but to kind of literally carry the weight of the world on your shoulders. And so in the literature, we are noticing that among trauma survivors, particularly those who identify with the strong Black woman syndrome. So again, identify with some of that pressure, feeling like you have to just take it and not be able to speak some of the things that, or deal with some of the things that you are facing. We see higher rates of binge eating. And we are wondering if it could be just the result. Often when individuals are engaging in binge and emotional eating, they're often not being able to speak verbally some of the things that they are most upset about, or feel powerless to change some of those things. And we continue to see that this might also be a factor in the development of binge eating among Black women. So now I'm going to show you some studies where we're going to just talk about what we know, right? There are definitely many deficits in our current literature, and we don't know enough, but we have learned some things about how eating disorders show up in Black populations. And so I'm hoping to share some of that with you. So this chart, just to orient you to the chart, this was a study that was done in about 775 treatment-seeking adults for binge eating or other eating disorders. And so what this study was looking to see is, what are some of the racial differences in just kind of the onset of disordered eating, the onset of obesity, the onset of dieting, and do we see any differences? So over here, this chart is showing just, okay, so the orange, the blue is the onset of obesity, okay? And so we see here that in Black patients, the onset of obesity was a little later than it was for, about similar to Hispanic, but definitely a little later than white patients. And then this yellow is the next step. Often in our country, when someone is trying to lose weight, they will often begin to diet. And so this yellow is the dieting, right? And you see across the races that it's different. And then the green is then individuals then developed binge eating. And then this orange shows that they developed binge eating disorder, which is represents severe binge eating behavior. What we see here is that Black individuals, their developmental trajectory, like they move much more quickly through these phases than we see, especially as compared to white participants. And what we notice is that when Black Americans, when they enter treatment, they often present with higher BMI, right? They have more weight, but they have the same weight, shape, and eating concerns, and they have similar or more frequent binge eating episodes. Another study was looking at Black and white patients who were coming in for treatment for disordered eating. And so we see here that across the races, we see that Black and white participants have very similar binge eating episodes. For those who aren't familiar, there's objective binge eating. So that's consuming on a standard and objectively large amount of food while experiencing loss of control. And then we have subjective binge eating episodes. So maybe the size wasn't as large, but these participants were still saying that they experienced loss of control. And so there's not many differences in between Black and white participants when it comes to some of these compensatory behaviors. However, we do see differences when it comes to, for the binge eating episodes, we do see differences in compensatory behaviors. So when individuals have bulimia nervosa, they also will have some compensatory behaviors like vomiting, laxative misuse, or diuretic misuse. And so in Black participants, we see much less vomiting, significantly less vomiting, but very similar amounts of laxative misuse. So what this means is that when patients are presenting and they might be describing symptoms of eating disorders, they may be, this individual does not have bulimia nervosa because maybe they don't have the vomiting. But what we see in our research is that they just use different things. And so that just further lets us know that we need to know how we can assess disordered eating in this population, because we might be missing individuals who might indeed be struggling with some compensatory behaviors, but they are not vomiting. So I also thought it'd be helpful for us to just think about COVID-19 and how that has impacted eating disorders in this population. So what we have seen just across, this was a study done by several authors here in University of North Carolina at Chapel Hill, and then across in the Netherlands and Sweden. And so they were looking at the impact of COVID-19 on eating disorders. And so what we see, just again, across these countries, is that people have been struggling, right? They have struggled. We have seen increased binge eating behavior, increased restriction, increased compensatory behaviors, and then anxiousness because individuals aren't able to exercise. When we have put it together and looked at a review of just what we've learned, we see that individuals, as COVID-19 was raging, right, those who were struggling with eating disorders were managing, one, they didn't have access to some of the things that they normally had access to, right? The things that supported them, social support, emotional regulation, treatment and care. People who were used to, you're used to seeing your provider in person. And so you had to switch to seeing them online. That was huge. And at the same time, you were dealing with increased risk, right? Your activities, your structure was disrupted. And you were fearful because, you were concerned that you might get COVID-19. And so the combination of this really caused an increase in eating disorder risk and symptoms. However, the challenge with much of our research in this area, as it's been done in predominantly white samples, and we haven't learned that much about how COVID-19 has affected Black Americans. So my team and I, we did a study where we interviewed 20 Black women who reported binge eating behaviors during the first wave of the COVID-19 pandemic. And we wanted to see what was the impact on COVID-19 for them. And so what we saw, so our sample, individuals are about 43 years of age, reported about between 5 and 6 objective binge eating episodes, had very limited episodes of any purging behaviors, and had achieved about, a bachelor's degree or higher. And so we came up with several themes from this interview study, and I'm going to present them briefly here. Participants often talked about how difficult it was to manage their eating as they were in their home environment all the time, and it felt very triggering for them. Participants also noted that it was difficult because there was no structure in the routine, and so it just made eating episodes continue and there was no stopping. We saw participants struggle with increased loss of control binge eating episodes, and also found it challenging to go to grocery stores and find foods that they were used to having not be available for them, and found themselves relying on food as a coping tool. Even though they were trying maybe to make some changes in the behavior, they found during the distress that popped and came up from COVID-19, they found that using food to cope was something that was really still meaningful to them. And so one of the participants said it this way: I find myself eating ice cream and cookies 2 or 3 times a day and bedtime, which are things I never did before COVID. And before COVID, I could eat a bite of any dessert and be completely satisfied. Since COVID, I have wanted to eat the whole dessert. That's different. That's very different. And I have been this way for years when it came to dessert. One bite enough, satisfied, done. COVID, I'm not satisfied with anything. And God, it feels like I'm never done. Another participant noted, I can't do what I want to do. I can't hang out. I can't see friends. I can't go to a comedy show. I can't go out. So I'm eating, right? And so these quotes, I hope they illustrate just what the experience was like for some of these women who were struggling with disorder eating before the pandemic and then had to navigate it during COVID-19. We also know that there are disparities in treatment access, and these are things that are really concerning. So what we've seen is that Black Americans are less likely to receive treatment for disordered eating. And then when they are in treatment, they're more likely to drop out. Now, some of the reasons for the dropout might be often we see that when Black Americans get engaged in treatment for disordered eating, they might make changes really quickly, okay? And so they might all of a sudden start to feel better. And that means that they may feel more comfortable not moving forward or not feel like it's necessary. There also might be a challenge with feeling comfortable with the provider and not feeling like maybe some of their concerns have been heard. So these are just some ideas. We don't fully know why they might be more likely to drop out of treatment, but I think we can infer that some of these spaces may not always have been as accommodating, as culturally relevant as maybe some of these participants might have needed. And so that might also have contributed to some of the challenges. So when we see some of the treatment access, this chart, so this study was done where they were assessing what are Black and white women as likely to receive treatment for disordered eating. And so here we see that Black women are the gray, and then the white women are the pink. And so they're very likely to receive treatment for a weight problem. But you see that white women are about 3 times more likely to receive treatment for disordered eating. And I think this has to do with understanding what an eating disorder is, and often eating disorder treatment has been in specialty eating disorder clinics. And so Black Americans that's not really the place that we go to receive care. The primary care setting is probably a more likely place that we receive care. And so these problems and these issues are continuing. We also see that there's just some disparities in lifetime service utilization when it comes to eating disorders. And we just see differences across race there are significantly higher rates of service utilization in white populations compared to Black, Latinx, and Asian populations. So this was a study that was done in about 30 multi-ethnic women, where the authors were looking to see why, right? What are some of the reasons that these individuals aren't seeking treatment? And so you see one of the most common reason is financially, right? Financial barriers. You also see that lack of insurance. It has been, challenging to pay for this treatment, worry that people cannot help, not knowing about the resources. You can see concerns about counselors not being the same ethnic background. So things that we've talked about, some of the things that are affecting just being able to feel comfortable seeking care. We also have to recognize the role of clinician bias. And so this study examined, this was psychologists, and they were giving them case studies. So they were presented with identical case studies where they had to demonstrate the disordered and really begin to understand and identify the disordered eating symptoms. And so clinicians were asked to identify if the woman's eating disorder behavior was problematic in a white sample, in Hispanic women, and in Black women. And so 44% were able to identify the white woman's eating behavior, and the Hispanic, about 41%, with the Hispanic woman's behavior as problematic. But you see 17% were able to identify the Black woman's eating behavior as problematic. And so that is very concerning, because what this is showing is that we don't know what eating disorders look like in non-white populations, and particularly in Black populations. Clinicians haven't really received the training and don't really understand what it looks like. So we might be missing a lot of eating disorders because it may not come in the package that many are used to seeing. So what are some of the reasons? I think one of the biggest reasons we see is that the patient is not underweight. And so what we see in our previous research is that when Black patients present for eating disorder treatment, they often have higher BMIs than white patients, white participants. And so immediately that often throws off, because then clinicians might have some perceptions themselves, misperceptions that eating disorders are only anorexia. They might be individuals are only preoccupied with a thin ideal. And if the patient meets BMI criteria for obesity, the clinician might feel more comfortable recommending weight loss or discussing type 2 diabetes, right? That might feel more appropriate at that time. Meanwhile, the eating disorder is hiding in plain sight, and they are not getting the focus and the help to really begin to call it out. And even sometimes the clinicians acknowledge we don't have the training. And so NSEED has been working hard to develop a screening tool, expert, to begin to kind of fix that problem, but we still need more, because the issue really is that we don't know what eating disorders looks like in non-white populations. And until that is really dealt with, then we're going to continue to miss people who really could use our help. So this is an example of a screener, something that could be used in the primary care setting that some do use, just a 7-question screener that individuals that often is very quick and could be given to kind of assess eating behaviors and patterns within the last 3 months. So the first several questions, just ask about any episodes of overeating and whether there was distress about overeating. And then it goes down and examines like if individuals felt like they had loss of control. Did you continue to eat when you weren't hungry? Did you, feel disgusted with yourself? And then they assess for any compensatory behaviors. And so this might be a quick screening option that might be helpful for those who are in practices and you need to have a screening tool for eating disorders. You might want to find something like this that could really be helpful to you. So now I'm going to take some time just to examine some treatment considerations and just begin to help us think about if you are a provider and you are working with individuals who are managing, Black individuals who are managing eating disorders, just some things that you might be able to do just to kind of switch the frame a little bit and prepare yourself to really begin to treat this population. So one of the things, a recent text that came out was Treating Black Women with Eating Disorders by Charlene Fuller and Mazzella Small offered the importance of what kind of questions do we ask in assessment. And often our questions are very colorblind. But if we were to focus on some culturally relevant factors, things that we know, we might ask a few different questions, bringing in the role of race, bringing in hair, right? Spirituality, gender, how those things have shaped body image. How has racism influenced the way that you relate to your body and experiences that might have influenced or shaped your relationship with food? Ask them questions about messages that they tell themselves about food and eating patterns. Also factors related to oppression that your client might discuss. Does your client identify with being all things to others? Is it difficult for them to ask for help? Is it difficult for them to speak their truth and be able to say when they've had enough? Understand the triggers that might be present to eat or to not eat. See, these are things that sometimes we haven't really done a very good job of bringing in to our assessments. And because we haven't asked certain questions, we may not have gotten the answers that we've needed to really begin to understand what disordered eating looks like in this population. Also, if we're going to do a comprehensive assessment, right, we're going to understand the history of their eating patterns and their relationship with food and the role of culture. I can't say this enough to really begin to unpack and understand how their culture has influenced how they relate to food and what they've learned about how they relate to food, what kind of stress they might be feeling, any acculturative stress. And so individuals probably wouldn't say it in this way, but if you invite the role of race into the room, make it clear as a clinician that that's something, that experience is something that you find that isn't critical to talk about, it might provide an opportunity for you to just kind of examine what it has been like if they've had experiences where they have been, the only Black person or in a sea majority white spaces, and how that might have impacted their eating behaviors and their relationship and perception of their body. Due to our previous discussion earlier in this presentation, we know just to assess the presence of food insecurity, poverty, previous trauma, and we know that eating disorders often are coupled with other comorbid mental health concerns, and to also assess the presence of those and even comorbid physical health concerns, whether it be obesity, type 2 diabetes. What we see is often there's disordered eating present within both of those as well. And then to examine cultural biases and beliefs that might be facilitative of disordered eating and might get in the way of, when it comes to like cultural ideas about body types, preferences, things that might weight stigma, what that looks like in their cultural context. So I think it's important to, especially as clinicians of color, when we are working with other Black clients. We share a culture between us. But sometimes I think we can have to remember that misunderstanding and bias can exist between us as well. And so the challenge when you share a racial background with the client, you will often mistake your experience for oppression. Your worldview might be swapped. You might assume, right, that the client has your same experience because you all share skin color. And so it's important to not do that, right? And to take the time to understand and examine the client's experience with racism, sexism, and gender identity concerns, recognizing that it's likely different from your own, and you do not know just because you might share that similar racial identity. It's also important to examine your racial identity status, right? We all have a developmental trajectory where we have been kind of processing and coming to terms with our racial identity within the context of this country. And so to think about your racial identity status and how you might be able to kind of understand where your clients is and how the combination of those two and what the impact of those two together, how that might really influence the relationship. And as always, it's important, I think, to recognize that bias is everyone is equally as capable of bias, and to be able to understand and do your work so that you can have continual growth with your clients in this way. For white clinicians who might be treating a Black patient, right? The first thing I think is so helpful to do is to examine your racial identity, right? And have done that work where you're thinking about your racial identity and its impact on you. And to verbally to say the words how you would like, you acknowledge the role, the influence of racism, and you want to learn and just open the door for the client to discuss their experience with the isms, knowing that they may not want to talk about it, but your job is just to be able to say and show that you are someone who they can talk about it with. And as you continue to build a journey where you're uncovering your areas of bias and your growth edges, this might be an opportunity for you to feel more comfortable inviting your clients, right, to share on the impact of racism in their lives. And then you think about your office space. What's it like when clients come in your space? You're sending messages all the time, right? How you can begin to set an atmosphere where clients feel, even, again, I know we do a lot of things telehealth, but we might have reason where clients have to physically come and see you, and how even you think about your social media platform or your website, how are things that you're advertising or language that you're using that signals to clients that, hey, you are concerned and you're a safe place to go to. And if you're not acknowledging race or talking about it or mentioning it at all, it does often has the opposite impact, and it may not communicate what you think it's communicating. I think sometimes clinicians may feel like, well, I want everyone to feel that it's a colorblind space and it feels safe. And it doesn't often, when you don't talk about race, it communicates that you maybe not see what the other person, and you may, not really see that in me. And there's nothing to be ashamed of. But so we have to show that we feel that way because it won't be assumed. So these are some various psychological treatments for eating disorders that have a significant literature. So cognitive behavioral therapy enhanced probably has the largest research literature on its effectiveness in treating eating disorders. And I listed all of these, not recognizing that we know for Black clients, I think it's clear that we have quite a deficit when it comes to the effectiveness. We just don't have as many studies as we should on the effectiveness of these treatments for Black Americans who are managing disordered eating. But we do know a couple things. So this was a study that was done in 2019, and they had about 579 participants. And so they looked across all of their participants who had participated in their research trials. And so what we see here are different forms of treatments to reduce binge eating. So in the blue, this is behavioral weight loss treatment, right? That's a very common treatment that we have seen that has been effective in the literature to reduce binge eating, even though I know many have their feelings about behavioral weight loss, but nonetheless, it is often a treatment that is used to reduce binge eating. Cognitive behavioral therapy is here in orange. And this was a combination of medication, and other behavioral weight loss and cognitive behavioral, it's like a combo treatment. And then this yellow is the control group. And so what we see in Black participants, they don't have the shaded, so they're just a solid bar. And so when Black participants are in these programs, we see that they are doing better than the white participants. Their symptoms, especially here in behavioral weight loss, their symptoms of their binge eating, this is their remission as it goes up, right? So how percentage of remission where these symptoms are going away. And we see that the Black patients, as they're getting this care, their symptoms are remitting, right? They're doing better. And what we see is that, I think what we can infer from this is that we already have treatments that have been found to be effective for other populations, but we just have not tested them in Black populations. But this study may lead us to suggest that some of these treatments that we already have may work well. So our work is to find out how we can get individuals to engage in treatment more so that they can receive more of, they can just receive the help that they need. So this was a study where my lab, we have been working to see kind of the feasibility of a different approach and helping participants. This was appetite awareness training was developed by Linda Craighead, psychologist out of Emory. And the program is to help participants to honor and adhere to their biological signals of hunger and satiety. And so my team and I were wondering if, since we know that Black women especially might use food as a coping tool, if we can help them relearn their biological signals of hunger and satiety and kind of reconnect with their bodies and begin to eat, and just kind of, again, bring that reconnection. And so what we were able to see is that in our study, we had 31 Black women with obesity who reported at least monthly binge eating over the last 3 months. And so we were just going to see, do they like this program, right? Is there the potential of really using this as a treatment for binge eating in this population? And so what we saw is that participants, they did like it, they were retained, and participants who were in the appetite awareness training part had greater decreases in binge eating scores. We also have to think about, again, if we know that individuals may not be coming in to treatment, how can we get self-help resources to them? And to recognize, because some of these texts, and we have to think creatively how we can package it in a way that can reach others. But I think COVID-19 has helped us see we have to change the idea of treatments being, in an office and recognize the digital platform. It's a plethora of help. And so how can we package treatments into in a way that we can reach people digitally, right? And we can help people. And then if those who won't come in, how can we give them access, especially if it's a binge eating concern? We've seen in the literature that self-care resources can be really helpful and effective to help reduce binge eating behaviors, but we have to find a way to begin to package that so that Black Americans and those who have been underserved by our current programs can get access to those treatments. And so this is just a model when we think about the levels of intervention and what we know about helping Black Americans in their as they're managing eating disorders. So at the individual level, right, if you have the opportunity to practice on the individual level, some of the first things that we're going to need to do is educate about eating disorders, because that providing that psychoeducation, you cannot do that enough. Because I often found among individuals in my research studies that usually is the first place to start, because people just aren't familiar with eating disorders. And then to provide just awareness on increasing alternative coping skills, because food is often used as a coping strategy. And so to be able to develop alternative coping skills to manage emotions, and then to begin to provide acknowledgement, support, validation for experiences of stress, racism, microaggressions, and trauma, because we know in the research that this is likely to influence eating disorders in this population. We have to also consider on the family level, just what food means and the expectations that might have been presented on what it means to, kind of our models for eating. And, we often laugh about having to clean your plate and some of our expectations that we might have received from our family members. These things really shape eating behavior, and to begin to unpack that system. And if you have the opportunity to work with a family to understand how to re-socialize and help family members to create a different environment around eating. We also have to help our providers, right, to understand that eating disorders may not develop as a response to the overevaluation of shape or weight. And there's other things. And because of racial stereotypes, it is easy to miss eating disorders, because just like the young woman was saying in the video earlier, it is easy to acknowledge that that we just don't know what it looks like in other populations, and we have missed people because of that. And also improve just access to culturally relevant definitions and norms of disordered eating, because it is not the same thing across races. And then in our systems, right, how can we recognize, if we know that Black Americans are often going to primary care centers more than any other place, how can we offer treatment for eating disorders in those places? And include assessments for eating disorders in programs that are going to be geared for weight management, because likely you will see a Black American engage in treatment for weight before they will engage in treatment for eating disorders. And so we have to take the opportunity to use those spaces as potential treatment for disordered eating as well. So just a summary, we have very limited evidence-based treatment for eating disorders among Black and African-American populations. And so because of that, there's going to be changes that are going to be required in the setting, in our recruitment strategy, and just how we can understand the relevant factors in treatment. And then we think about what we know about equity, and we might have to shape our treatments differently if we're going to reach people who have been underserved, have not been included, and they haven't been the norm as we've been building our treatment. So it leaves a great deal of opportunity for our research field and our clinicians to begin to remodel, right, build differently as we think about opportunities to treat eating disorders in Black Americans. So in summary, there's similar or higher prevalence of binge eating, particularly with bulimia nervosa and binge eating disorder in Black Americans. However, we continue to see disparities in access and retention to treatment, but we are learning that it's bigger, right? It's not just about being the desire for thinness, but we're recognizing these other factors: poverty, racism, a culture of stress may also contribute to the development of eating disorders in this population. And so because we have these limited evidence-based treatments, we have to be creative about building and modeling something new. And we have to continue as researchers to examine the prevalence and the nature of eating disorders in various racial and ethnic populations, and examine differences in treatment response. So thank you all for presentation and for listening, and I look forward to answering any questions.
Thank you so much again, Dr. Rachel Good, for a wonderful presentation. I just wanted to give you guys a few quick updates before we move into question and answers. We will be sending out today's PowerPoint slides tomorrow. Ms. Courtney Pierce will send those out, and you'll also receive instructions in that email regarding NADAC credits and continuing education credits from the APA, how you are to redeem those and the respective persons to email. You'll also receive an evaluation form sent by Mr. Corey Ware from the African American Behavioral Health Center of Excellence. I'll now move into our question and answer segment. If you have any questions, please list them in the Q&A box. I'll start to read those now. And also to mention, this webinar will be available via the NC Training Center at www.ncdas.org within 1 week from today. Any unanswered questions will be sent via email 1 week from today to all of the participants in today's webinar. So the first person asked, can we have a link to the clip, Dr. Good? I think that's the clip that you showed within the presentation.
Yes, I think I can share that. So I'll try to share that with you, Lachelle, that you might be able to pass that on.
Thank you. And then the next question asks, what are your thoughts about prevention and identifying people at risk of developing a disorder?
Yeah, that's a important question, because I think we do need to shift to that place where we are kind of knowing if individuals might be struggling. So if I think about in a primary care setting, individuals, one thing we've seen in the research is that often maybe the year before individuals have gone for weight management treatment, there might be a period of rapid weight gain. So that is often a sign that there might be disordered eating present. I think there's also just maybe just sometimes people are very anxious about some of their eating behaviors. What we see is that in our country, when individuals engage in kind of dieting, sadly, often dieting is kind of what precedes the development of an eating disorder. And so although we know that there are other reasons, that is still very a commonplace. So sometimes individuals will engage, and if they engage in like a yo-yo dieting, and they kind of are gaining weight and then they're losing it again and gaining weight, it's easy to kind of just go slowly. You might be in a healthy weight management program. It's easy to also get into periods where you're doing some restriction. And so when we see individuals restricting their eating, it can also really influence, it's like a rubber band effect, and they can go the other way, and it can lead to some more binge eating behavior. So that's often, if someone's on a restrictive diet, that's another place to watch that may be for the development of disordered eating.
Thank you so much for that, Dr. Good. The next question asks, how do you suggest that white providers or parent coaches reach out to and connect with individuals in a fairly segregated area, for instance, Western North Carolina?
So I always think it is good when, if you are the white provider and you're trying to kind of enter a community that you're not a part of, I think it's always good to go and find gatekeepers in the community and to build a relationship with them first. Because in order for you to get access to anyone, truly, people are going to have to know that you're okay. And someone else is going to have to, you can't do that yourself. Someone else is going to have to vouch for you. And so I think it's important for you to develop a relationship, because there are probably people already in the community who are providing resources, who are shared, these things probably already exist. And it's important to partner with some individuals who are already helping others, and to, and to begin to kind of just create just trust and a relationship, and then think of it as you helping other people, and joining and showing up to spaces where you might be the only one in that space, and beginning to kind of just put yourself out there and want to meet people and want to collaborate. And it might be a little challenging at first, but it's just, you're going to have to demonstrate that we can trust you, and it's going to be challenging without some buy-in from the community.
Thank you so much for that, Dr. Good. I think we can get 2 more questions in. The next question asks, how do we let people know in the Black community when services are available for eating disorders?
Yeah, oh my goodness. So I think it's first, how do we have a conversation where we even know how to present eating disorders, right? And be able to talk about what an eating disorder is. And so I can think of various, I've been on a couple panels where they just kind of had a talk session where you just invite people. Often when I advertise for my studies, I invite people to talk about their experiences with loss of control eating, emotional eating, experiences, just feeling out of control around food. Like, these are certain terms that I have found that just kind of resonate with people. People know what that means, versus let's talk about binge eating or bulimia nervosa. That may not resonate. So we need to kind of meet the people where they are, and but people can talk about their eating behaviors, because if you're managing with disordered eating, it's disturbing to you, it bothers you, right? And so you know that feeling. And so creating spaces, I think, where you can help people kind of talk about that, and then providing just information. I love social media in that way because it's a way that, and in our lab, we've been able to, just kind of link people to things that are going on, linking just various clips, but just opportunities to show, just make it relevant to individuals. And if someone can share their story, I think that's probably the most powerful testimony, because people are able to relate to what an individual has been going through in that way.
Thank you so much for that, Dr. Good. And I'll go ahead and mention our last question before we wrap up. The remaining questions will be sent to Dr. Good, and she'll send responses via email within 1 week. How do we educate the local Black community on eating disorders and the need to refer?
Yeah. I think, so first we have to just name the misconception. Eating disorders are not just a white woman's disease. We got to say that over and over again. We all can have eating disorders. And so we have to name the misconception, and then they're going to have to see, we're going to have some brave people. And I know there are individuals who have overcome an eating disorder who would like to help others. And I think often hearing from people who look like you and who have kind of dealt with this, who have walked this journey and come out on the other side, is often a tool that is really powerful, for that people can kind of, I see me in you, right? Representation matters. We know that. And so we know that we're going to have to be able to help people see themselves in it. And so if we don't, and often our images, we don't have images. And I love that we have had, I think of a Chia Red, who has come forward and talked about her struggle with eating disorders, other writers who have talked about their struggle with eating disorders. And I think that's probably something where we can tack on to someone who looks like us, and we're like, yeah, I get it. You understand what I'm talking about. I think that's going to help us to be able to treat and make people more aware.
Thank you so much for that, Dr. Good. I want to thank you all for joining today's session. We will send contact information for Dr. Good to you all with the responses for the unanswered questions that were not addressed today. And we will also provide you with those slides tomorrow. Dr. Good, do you have any closing remarks that you'd like to share?
No, I'm grateful to be here, and thank you all so much.
Okay, thank you so much. And we'd also like to thank our partners, Dr. Tyus and Dr. Corey, Mr. Corey Ware over at the African American Behavioral Health Center of Excellence for their collaboration in today's webinar. Thank you all for joining. And please remember that you will be able to access this webinar via the NC Training Center within 1 week from today. Thank you so much.
Thank you.